Well, thank you very much. First of all, I certainly understand the summer issues. People agree to do things and then realize, oh my goodness, all of a sudden it's July the 4th and I was planning an 8-day weekend, so I'm taking the week off or whatever. But anyway, I set this up today, hopefully, to engender some discussion. Maybe that won't be the case and we'll just roll right through it. But by all means, for anybody joining or currently on at any point in time, please feel free to speak up if I'm not making sense. The whole point of today's discussion is to talk about the use of technology in the delivery of healthcare. And some people get pretty caught up on the semantics of distinguishing between telehealth and telemedicine. And quite frankly, I think that's a lot of wasted time. But in general, telehealth is the big umbrella under which telemedicine exists. And for the most part, we're going to be talking about telemedicine. If you can advance the slide, please. So as you see on this slide, I have borrowed liberally from the Altarum Institute, which plays a big role actually in advocating for better healthcare delivery in rural areas. And I think this is certainly one area where telemedicine has played and will continue to play an increasingly important role in the efficient and more democratic with a little d delivery of healthcare. In other words, I think disparities of healthcare delivery, access to healthcare are certainly enhanced by the use of technology in whatever means of healthcare delivery we're talking about. And we'll look at different ways technology is used, not in any great detail, but just to lay the landscape for how we can think about the use of technology in improving healthcare delivery. And certainly those of us who live in the West, particularly in the Intermountain West, most of which, quite frankly, is almost frontier by definition because of the lack of density of population, the utility of technology to, in a virtual way, shorten commute times from the recipient of healthcare and the provider of healthcare is very important. So as you see in this quotation that I took directly out of their report, out of the Altarum Institute report, rural Americans face a unique combination of factors that create disparities in healthcare not found in urban areas. Moreover, there are several economic factors, educational issues, quite frankly, almost being forgot by legislators, as well as the isolation of living in frontier areas that really conspire in a way to make it difficult if you live in rural America to get the same health care that people in urban areas get. In 2010, the U.S. Census estimated that almost 60 million people, or approximately 20% of the United States population, lived in rural areas. However, only 10% of the nation's physicians practice in those rural areas. Moreover, access to specialty care is particularly impeded when one sees that per population, per 100,000 people, there are 401 specialists per 100,000 in rural U.S. compared to 910 in the urban areas. Next slide, please. So some of this will be a bit self-perpetuating. I just point out in this slide that at the University of Utah, in our healthcare system, we serve a large geographic part of the United States between Denver and San Francisco. And at least at this latitude, we are the only academic medical center. And you see by virtue of this map that we have used telemedicine to reach out into significant parts of Montana, Idaho, and western Wyoming, eastern Nevada, and actually as well in parts of Colorado, including Grand Junction. Next slide. Hit it again, please. So in the big picture, telehealth has at least 4 components. Next slide. There is the traditional telemedicine, the old iconic form of a provider with a camera on one end and a patient with the problem on the other. There's also the situation where that might not be adequate, that an examination of the patient might have to be performed. So another provider is brought in order to complete that telemedicine encounter. But basically, it's one provider and one patient in a remote area being connected by a camera, by technology, by a teleconference, so to speak. Then I know that you are familiar with Project Echo and what we're going to call e-consultation. E-consultation can take on many, many forms, and we'll see another form of it that we have here at the University of Utah. But Project Echo is provider-to-provider consultation, mentoring, such that the mentee, or the person who is making a case presentation to a specialist on the other end of the camera, so to speak, will then take the knowledge gained by that curbside consultation, that e-consultation, and treat a patient 2, 3, or 4 based on the knowledge gained in that provider-to-provider interaction. Next slide, or next hit. So then, more recently, virtual visits or digital health have become the rage, quite frankly. Almost every significant healthcare system in the country is trying to set up virtual visits where you have, by virtue of the web, you can have almost immediate access to a provider, either a physician, nurse practitioner, physician's assistant. And as well as these virtual visits, digital health would also include the reporting of data through monitoring devices from the patient to a central location, such as reads from a blood sugar measuring device for individuals who are diabetic with a pump or an artificial pancreas, so to speak. Next slide. So again, here's a bit of an advertisement. This is the virtual visit. You see the patient, in this case, a child and her mother, talking to a provider via the web using a tablet format for this. And these are widely available, not only in the University of Utah system, but here in Salt Lake City, Intermountain Healthcare also has this type of option such that you can call in, link in, and have your issues dealt with in an almost instantaneous manner when the circumstances are appropriate. Next. These 2 bars in 2015 and the anticipated growth of this modality in 2020 are demonstrated for you here. Dollars currently being generated in this virtual visit are approaching $15 billion now and are anticipated to be more than twice that by the year 2020. Next slide. So there are several things driving this type of access, whether it's virtual visits or just virtual care by any of our telemedicine modalities. Next punch, please. The biggest driver is that we anticipate going from a system that compensates on the basis of volume to one that compensates the providers or the provider system on the basis of the value of the healthcare delivered, of its timeliness, of its efficacy, of its appropriateness. Certainly in making people or giving people greater access and leveling the playing field regarding the type of care that can be delivered remotely by virtue of technology, we're expanding coverage and we are addressing to some extent areas of physician shortage in rural areas. Moreover, the customer is demanding it. We have ability to address issues such as a wave of influenza that may hit in the wintertime, requiring significant public health issues. And finally, by virtue of all of our telemedicine modalities, whether it's traditional telemedicine, virtual visits, Project Echo, the triple aim is to get the right medicine to the right people at the right time. Next slide. So as we think about the driving forces again for all this virtual care, the most significant factors when you look at surveys, when you ask providers and patients most what they want out of virtual visits, it is improved access, and that is almost universal. 95% plus of the respondents see the virtue of telemedicine in improving access. Moreover, by virtue of the fact that your access often is to a specialist or individuals who at least have significant experience with this problem, that improved outcomes is a consequence. And as I have already stated, utilizing technology to virtually put providers into rural and other underserved areas certainly addresses provider shortages. Now, whether or not there is truly streamlined workflow in all forms of telemedicine, I'm not so sure that that's the case. As you see, only half or just under of the respondents suggested streamlined workflow. Because I have intimate knowledge with Project Echo, I certainly see the streamlining of Echo, but not necessarily the one-on-one, more iconic or traditional telemedicine. Be that as it may, all forms of the use of technology to deliver healthcare, I think, have the virtues, particularly those outlined in the orange bars. Next. So telehealth services are broken out at the University of Utah under those that are more traditional telemedicine and those that have to do with Project Echo, and I will not spend much time at all today on Project Echo since I know you're very familiar with it. And we're really here to talk more about the use of telemedicine or telehealth services in the management of chronic diseases. Now, stroke is a result of a chronic disease. It has its acute component, and for that reason, it really lends itself to both the acute care telemedicine service where you have a specialist on one end of the camera and you have a patient and a provider in an ER somewhere else. But managing the things that led up to that are more of a chronic problem. However, the two iconic forms of telemedicine at the University of Utah are actually stroke and burn care, which have been going on for 15 to 20 years in the case of those two. Obviously, as you see, there's a long list of those things that are being addressed in the traditional provider-patient interaction or provider-patient and another provider on the other end, including critical care. There now is a 24/7 telemedicine access for those hospitals that have developed this relationship with the University of Utah Critical Care Network. Oncology is addressed mostly in the form of tumor boards without patients being present, but obviously telemedicine certainly lends itself to making tumor board presentations regardless of where you are, and you have access to this multidisciplinary team of individuals who are making decisions, making recommendations, so forth and so on. Next slide. Also listed are the programs that our Project Echo has instituted. Some of them are no longer up and running, but the vast majority of these are and continue to provide care for both acute and chronic conditions. Pregnancy care is a little bit of both, but it's a significantly successful program that was started about 2 years ago by Dr. Aaron Clark, and already has had a major impact in reducing the significance of peripartum hemorrhage in our population. Next slide, please. So telestroke comes out of the Department of Neurology. Dr. Jennifer Majerzik is the director of that program, and there is a stroke neurologist on call 24/7. Next. Obviously, the reason this is done is to address stroke issues in a timely fashion to prevent progression and save not only the life, but significant quality of life for those individuals who are in the early phase of a cerebrovascular accident. Moreover, sometimes the stroke call turns out to be not a stroke call, so you get help in appropriately managing and or referring these individuals who have some form of neurologic entity that is not cerebrovascular accident. Regardless of what it turns out to be, you get timely diagnosis and treatment. Next slide. Teleburn is another one of the university's iconic telemedicine programs. It's been going on, as I say, for over 20 years. And much like the issue with telestroke, you get timely diagnosis and treatment. You get appropriate advice regarding those who should be referred to this burn center and those that can be managed locally. And it's Dr. Cochran's opinion that about 30% of the teleburn referrals they get can be managed there in the community, which are saving unnecessary and very expensive air transports of people with burn and soft tissue injury who can be managed there at home with the help and advice of our burn folks. Next slide. Obviously, Project ECHO, with which I'm associated. We have teleplastics, which again provides both traditional provider-patient as well as provider-to-provider consultation. And then Dr. John Ward with tele-oncology, again, which is more of a learning or a teaching cohort regarding oncology presentations. Next. Lest I leave out one of the most critical and chronic issues with which all providers have to address and for which the rural areas are not very well staffed are behavioral health issues. So our telemental health issues are really addressed by two different modalities, sort of crisis interventions for social workers, plus an online format called GATE, G-A-T-E. I don't know what that acronym stands for, but GATE allows the provider seeking advice to put in history in a formatted way, and within 24 hours, a psychiatrist who is assigned to the GATE project for the day will assess the history, get back to that provider with recommendations. That is simply one form of addressing mental health disorders. There are many other forms as well as many other areas, as you know, that we can use this modality of virtual interaction to address. Next. As you see, Burn launched in 2005, is totally self-sustaining at this point. There was a grant at that time, and you can see from the 12 consultations delivered in 2005, a decade later, they were up to almost 500 consultations on an annual basis. And in so doing, getting appropriate, timely care to those burn victims and helping providers, when appropriate, take care of burn and soft tissue injury at home. Next. So in order to make any of these telemedicine programs successful, you have to have a clinical champion on one end. Next slide, next button. As well as a receptive audience on the other, and you have to work out an efficient workflow. The request from the specialty end needs to be reasonable, and the information asked of the presenting provider needs to be meaningful and asked for in a way that is efficient for that provider. In so doing, then you can have a very efficient transmission of data. You can have a discussion that is more aimed at addressing the problem rather than transmitting data. The technology continues to improve, just as this software we're using today to come together in this virtual format. Technology continues to get more efficient, more user-friendly, and now, of course, is HIPAA compliant. Lastly, it is still people-to-people interaction, developing trust, developing a relationship that makes it possible to do virtual visits, telemedicine. These personal interactions are no less important in the virtual space than they are in the more traditional space. At the end of the day, if we're not doing a good job, it doesn't matter how we're doing it, and that's true in telemedicine as well. We need to make sure we are accomplishing what we think we're accomplishing. We should be measuring our outcomes. We should be making it easy for the providers asking for help to get feedback on how they are doing, as well as give feedback to the specialty arm about how that program is working out from the other perspective. Just a short list again of the Project ECHO programs next. These are our points from which we have had providers in the 5+ years that we've been doing Project ECHO. They're obviously not all active, but you can see the reach of a web-based interactive video conferencing system is quite dramatic. And I will just say that all of those providers on the West Coast found us by word of mouth, and some of them remain our most faithful attendees, sort of underscoring the true relationships that develop as a result of these virtual communities that get together every week or every other week to address common problems such as hepatitis C, advanced liver disease, pregnancy issues, behavioral health issues, and so forth. Next. So getting back to the reason we came together today to discuss using telemedicine in the treatment of chronic disease in rural communities. Obviously, as we have already stated, getting high quality, affordable care in rural populations can sometimes be a challenge. And those challenges are made even more significant when one understands that the most common chronic issues in our country today disproportionately affect rural populations. And those issues really relate to the metabolic syndrome and its many manifestations. Manifest in the form of obesity and obesity-related health issues, including diabetes mellitus, coronary artery disease, as well as other issues of substance abuse. Alcohol abuse, common everywhere. It's been around for a long time, never going away. And more recently, the increasing problem that is at least as acute in rural communities would be substance abuse. Whether it's methamphetamine, heroin, or other substances, we are seeing, not necessarily in the West, but certainly in parts of the United States, such as Appalachia, Ohio, ravages of the IV heroin epidemic that is sweeping parts of our country. Bullet point number 3, 86% of all healthcare spending a decade ago was for people with one or more chronic medical conditions. So the issue of chronic illness is the driver that necessitates a huge part of our country's economy being spent on health issues. The medical costs linked to obesity alone a decade ago were $147 billion, and certainly higher than that now. Annual medical costs for people who are obese are about $1,500 higher per year than for those with normal weight in the year 2006. And again, undoubtedly, now that we have more obese people and they're more obese than they ever were, more than a decade later, that number is going to be even significantly higher. The total estimated cost in 2012 to address diabetes was $250 billion, $245 billion, $176 billion in direct costs, and another $70 billion in decreased productivity. Diabetes diabetes 5 years ago was ravaging the country, is even worse now. Next slide. So this chart is set up to underscore how rural states are significantly disadvantaged when it comes to addressing obesity and diabetes tightly related issues. So you see all the colored states are considered rural. And for the most part, they all match up with the highest rate of adult obesity and the highest rate of diagnosed diabetes. So again, rural areas significantly hit by our chronic diseases that rank as high as anything else in healthcare costs, and really occurring in areas where access to care, because of the rural and or frontier nature of the state, is diminished. Next slide. So as I have said and suggested, telemedicine, I think, is a solution, one of the solutions, not the only, but is one of the solutions to the issue of rural healthcare delivery. It helps eliminate distance barriers, as we've discussed, and it levels the playing field. The disparities in the delivery of healthcare between an urban and a rural environment can be mitigated almost completely by the use of technology to leverage the knowledge, to disseminate the knowledge of the specialists in urban and academic centers into the rural communities by developing these virtual relationships with patients and providers in the rural areas. And this is particularly relevant to the ongoing management of chronic problems, diabetes, congestive heart failure, asthma. Not only can you deliver advice and mentoring, but remote monitoring of conditions such as diabetes with remote monitoring devices to document blood sugar management. As we know, in diabetes care, tight blood sugar management significantly reduces the impact of diabetes on associated end organ targets such as the heart, the kidneys, the eyes. So in these circumstances, chronic conditions really lend themselves ideally to the use of technology in access to and diminishing the disparity of healthcare. Next slide. There are challenges, however. Not everything is perfect in that environment. In many states, I should say in most states, telemedicine services are not covered by insurance to the same extent as they are in person-to-person encounters. And to some extent, maybe one could understand that when a very well done physical examination is necessary, but quite frankly, that's rarely the case. As you see in bullet point number 2, one of the things that should be done is insurance plan administrators and providers need to get together to mutually agree on the benefit of telemedicine and technology in the delivery of healthcare to determine these coverage benefits, reimbursement policies, options for equalizing in-person versus virtual visits. Mississippi, as you saw in the chart, one of the states hardest hit with obesity, diabetes. It is largely a rural state, and their legislature has really taken on this task of utilizing technology to deliver healthcare. And Mississippi is recognized as one of the leading states in the use of telemedicine. And it basically mandated through their legislature that private insurance companies must pay for services at the same rate for telemedicine and in-person services. Medicare has not stepped up to the plate. It has really, really stringent requirements for how it will pay for telehealth services. Currently, they are only paying for telehealth services in those areas officially designated as health professional shortage areas. And it requires a face-to-face interactive video consultation. It's not going to compensate at this time providers who discuss the case without the patient being present. As I indicated earlier, however, telemedicine is not a replacement for any kind of physical examination unless you have the provider in the room doing the physical examination who's able to convey to the other person on the other end of the camera the findings of such. With that in mind, we understand that the rules or the risks, perhaps, of telemedicine are not necessarily going to be the same as they are for virtual visits. But again, if we all come together, plan administrators, providers, and patients, and determine where we can create a mutual agreement, we should be able to push this forward. Licensing is also an issue. We need a national agreement that providers of telemedicine services don't need to be licensed in every state into which their services may reach. That seems like that would be a very easy problem to address, but it goes on and on and on without a solution. And then finally, we all have a situation where the patients that we see in our offices or in our emergency rooms or get admitted to our hospital, even you, I'm sure, the last time that you saw a provider that you had never seen before had to sign consent to be treated. So the issues of gaining consent for virtual encounters is another big problem. So this is a long list of challenges, not that any of them can't be overcome, but this is still what we are dealing with in the area of telemedicine in the management of both acute and chronic diseases. Next slide. So at the higher levels of decision making, there are some top federal priorities, and I think it will be from the feds, where there is a trickle down of decisions that will have an impact on the states. And the first thing that everybody has on their mind is reimbursement. So Medicare parity would be ideal. There's been a lot of effort gone into it, but still moving in that direction has been exceedingly slow. Moreover, there are Social Security Administration restrictions on compensation as well as Medicare. All of that federal mandates, all of those federal mandates need to address this issue and level the playing field across all states. There should be incentives for innovation. And one of those incentives, as you see under the innovation bullet point, is a bill that was put forth into the Senate and the House after it was passed in the Senate and ultimately signed into law by President Obama in December. A bill called Expanding Access for Health Outcomes. Interestingly, sounds a whole lot like Project ECHO. Well, it's exactly aimed at asking the Secretary of Health and Human Services to analyze Project ECHO type healthcare delivery platforms for efficiency, cost, efficacy, and barriers to institution. So the ECHO Act was a true bipartisan endeavor. It was passed unanimously, both in the Senate and by acclamation in the House before it was sent to President Obama last December. Finally, I've mentioned some of the issues that restrict access or restrict application, I should say, to telemedicine services, in that they can only be rural, or they must be in an emergency room or a hospital or a designated office. You can't do it in the patient's home. So all of those things are still in the process of being worked out. And then obviously, those of us who provide these services must certainly take exceptional precautions to be discreet and to follow HIPAA rules regarding sharing of data. Next slide. So having said all that, I think this is the vision of the future that relates to the use of technology in the delivery of healthcare for both acute and chronic diseases. The network that is developed hopefully will have somewhat of a nationwide feel, but certainly we will see regional, if not local, hubs that are capable of connecting providers and patients, multidisciplinary teams of providers with either other providers and or patients, getting into the homes with monitoring devices to monitor the impact of the treatment of diabetes, to monitor the impact of the treatment of asthma, things of that nature. In the center of this, you see the word right, because we want to do it all right. Treating patients require that we have the providers in the right place, that we have the delivery of care in the appropriate method, that we deliver it in a timely way, and that we keep the costs down in order to make sure that we are addressing the value issue of our healthcare delivery. With that, I think that's the last slide. If you want to hit it one more time, yes, that would be it. So I am open to your questions or comments.